Hello and welcome to another episode of A Dose of Digital Health, where today I'm really happy to welcome Priya.
Thank you so much, and thanks for the opportunity.
So Priya, tell me a bit more about how you ended up here in the surgery.
Well, let me take you back to my dad,
Okay.
who set up the surgery back in 1980. And we used to actually live in the house upstairs, me and my brother, while my mum was a receptionist and my dad was the doctor. And they built the practice by going around to the neighbours, inviting them to be part of their practice, and they've built that up to about 5,000 patients now over 40 years.
Well, that's incredible. And you decided as a young girl that looks like the world for me.
Well, it's what I saw, which was absolutely fantastic. I could see my dad giving back to the community, my mum. I wanted to be part of that, and I've been very privileged to join the practice actually. On the side of that, I have gone and done my own things with regards to management and healthcare on a wider scale. But actually the one-to-one interaction with the patient is really valuable on a daily basis.
That's wonderful. So tell me a bit more about the community here and why it's so special.
So the community feels part of the surgery actually, from the building blocks, especially the people that live on the street just around us. We have approximately 5,300 patients now, of which 96% are from a minority ethnic group.
Okay.
We've got, and if we spread that out into Slough, that's about 64% of Slough is from a minority ethnic group with more than 150 different languages spoken.
Good heavens.
Yeah, so lots of different barriers, lots of different language issues. We have quite a lot of immigrant population that comes across as well into Slough. So lots of need, which is great, but the community brings a lot to the surgery themselves, okay. What they want from us, how they want us to interact with them. We have quite an underserved population as well. Across the whole of Frimley ICB, the integrated board, 69% of the whole population of Frimley underserved population lives in Slough alone.
I wasn't aware of that, that's incredible. Okay.
Yeah. So, and the average decile deprivation in my surgery is about 3.6.
Right.
So quite a lot of need, but quite a big community feel in and around the area.
Okay, so clearly some challenges. So the languages, what other than the obvious then are the challenges from a health perspective in your community?
So I think because, well, let's talk about health inequalities, I guess. And we know that we have significant health inequalities in Slough. Compared to our neighbouring town, Windsor Maidenhead, there's a 10-year life expectancy difference. Yeah. We have 15% of children living in low income houses. And we do know that the wider determinants will feed into the potential health inequalities that already exist. This was expedited in COVID.
Of course. And
therefore people in Slough have disease much earlier in their lives. They have many health conditions at an early age. And this goes on to impact their children and the next generation and the next generation.
Yeah. And digital health is what we're, the Dose of Digital Health is the podcast. And when we first spoke, I was really interested because you talked about really embracing digital health many years ago, and you obviously saw the benefits that could potentially bring for your community and the challenges that you face. So when did you first really start to think about a digital solution or digital solutions and how they can help, and what made you think about that? Was it something you saw at an exhibition?
Yeah, actually it was COVID-19. So what was really interesting, on the 17th of March, I was meant to have CQC come to my practice, and I was preparing my answers, and we brought out electronic prescriptions. So the first of the digital different access points for patients. I only had 20% of my patients kind of signed up. Yeah. And I was preparing my answers, and I was like, I have a large minority ethnic background population who don't know how to access digital. And by the 20th of March, COVID-19 hit. Yeah. 96% uptake.
Really?
From 20% to 96% within a week.
Within a week. So they could do it.
And that's really interesting for me, that I think we've made assumptions about these communities. And actually what we need to start to do is co-create with them, understand which digital solutions do and don't work for them, and start to really expand that.
And I wonder actually if that was also the families coming together and recognising that they really had to help their family who were reliant on those radio prescriptions. So they actually sat down and helped them with the app or helped them complete and fill it in. So that community and the family really comes together to do that.
Absolutely, and another thing we found in COVID-19 was that 13.9% of Slough's population lives in multi-generational households.
Okay.
So exactly what you're talking about,
Yeah.
the younger generation therefore realising these different ways of accessing help and supporting their parents and their grandparents in the house actually. So that's become an interesting part to play in Slough. And in Frimley ICB, we actually remote monitor about 7,000 residents within the Frimley system. Those that are most frail in the system through risk stratification, and we haven't seen a health inequalities disparity between the groups because we're using the other carers in the home to support the way we can support families in a different way closer to home.
And do you think COVID-19 has helped in that respect, possibly brought families closer together again?
I think they have brought them closer together and appreciate each other's problems and different ways of access, but I think it's completely changed the digital agenda in the NHS. I think it's expedited it by years, and the way the population has reacted to that digital access has been interesting, and we still need to get it right, but I think it is working. So, previously we would see all our patients face to face in general practice. Now I'll be using text messaging, videoing, telephoning, face to face, and it's created much more capacity for me to see many more patients. And actually, the patients get to choose what type of access they want. And they're like, I want a face-to-face appointment, they'll get one. Actually, I could do with a telephone because I'm at work. So it's really sort of changed the way primary care significantly works.
Yeah. And I do wonder though, thinking about that definitely works for you. If that's because you have this such strong community sense, your practice here is part of the community, and therefore your patients and your cohort of patients have faith in you as a clinician. Whereas potentially, this is just how I'm thinking, potentially in other scenarios where there might be a larger surgery with more locums, I know you'll use locums here, but more locums more frequently, so they don't have that relationship which we used to have with our GPs, that they would have that same trust or faith that they have with you to take a phone call consultation or video consultation because they know your father, so it's about that family.
Absolutely.
I wonder if that might be one of the reasons it works so well for you.
So I think you've probably got a good point there with continuity of care, which is kind of key when you need to know when to bring someone in or not. I think interestingly though, the younger generation likes to access health this way now.
Yeah.
So I'm not saying it's for the older generation, I'm not saying it's for everybody, but actually with the, as I call it, the Amazon effect.
Yeah.
That's the way the younger generation likes to actually access health now, is
Yeah.
what I see. When they really need us, they need us now, they want to be kind of managed within 24 hours, 48 hours. People's lives are so much busier than since COVID. That I think it is a new way forward. I think we need to start to bring safety mechanisms into it though, of how we're using it, and that's how we start to get intelligent with the data as well, and pick up signs and use the data to understand where potentially a patient's care is going the wrong way.
Yeah.
And I think in time we'll be able to get that to that sweet spot where we will know who to bring in when and how through the data, because there's red flag symptoms or red flag signs that's being picked up.
Yeah, I think it's interesting you mentioning the younger population there, because obviously I guess from the time they're teenagers, you're not going to see them, you don't want to see them for 20, 30 years, really, until maybe some of these longer term conditions start to kick in, with age and things like that. So just thinking back to the younger population, are you able to offer those services then very quickly in terms of responses and text messages, video calls? Can you serve them and at the same time the older population.
Yeah, absolutely. I think because we understand the complexity of the patients as well differently. So we do use something called John Hopkins segmentation, where we understand the underlying complexity of the patient, and then we add on the need. Therefore, we're able to really understand how they want to interact with us. Many of the times I get an e-consult and patients gone on to the actual website, filled it in, and they said, I just want to be contacted by telephone, or I don't mind a text message. And they've actually written that in the consultation, that I'm happy to be interacted in this way. I think it's about giving options. I think it's about giving access. But what we need to work out is prioritising that access and the need to make sure that we don't miss people on the way.
Okay.
And that's what's really key.
Yeah. So talk to me about e-consult then, and how long you've had that, and was it e-consult a choice that you made, or other solutions or systems, and how is it working?
So e-consult was probably one of the first e-consultations that came out, and therefore we kind of spread that across the system. It works differently in different practices. Different populations take up to it a lot better than others. For example, because I have 96% minority ethnic background, it's much harder for my population to use. There's a few more questions, and therefore we generally go for sick notes. But actually those that can use it, as I said, multi-generational households, they help family members fill it in. We get a greater understanding of the need of the patient before we even see them or talk to them. It gives us more information to make an informed decision. What I find about digital solutions, they're all enablers of giving us a rich understanding of who we're speaking to on the phone, what they're wanting out of it, and who they're wanting to see. So if we can start to get that right at every level in the system, not just primary care, but secondary care, A&E, one-on-one, out of hours, then we can get the system starting to really move in one direction. And that sounds easier than it is. It never replaces clinical decision making. That's where I think people get worried. It's not about replacing clinical decision making. It's about really enhancing that clinical decision making to basically be able to get the right patient to the right time, first time, and save lives. And I think that's what's fundamentally different.
No, I agree. And at DXS, we are clinical decision support, and that's really important, that it's clinical decision support. It's the support element. So we help you or enable you to get more out of your day. I think essentially is what it is. And towards the end of the day, 2 or 3 o'clock, maybe you're doing some more video consultations where you become more tired. People do so, and it's helping make those clinical decisions, isn't it?
Absolutely. And this all is fed back to the patient and the population. The more we can give in a different way, the more we can start to become efficient in what we're doing. We'll create more time and space to serve populations that potentially we don't get to or need greater need.
And one of the things that we think about is the challenge that, moving on to AI, and just a quick discussion about that, because everyone thinks about AI, is that there is a worry and concern, I think certainly amongst some clinicians and also patients, that AI is making all the decisions. And I mean, there are some solutions out there that present that they can do all the work, and which I think is a worry potentially and a concern, because as you say, you need that clinician as a gatekeeper and a point that says, I need to look at this now. So thank you, AI, for presenting me with all the data and highlighting the red flags and scanning the population and all that. So that's great, but I need, as a clinician, to then look at that and say, okay, now that's correct, but that one I'm not sure about, and we'll bring that person in, and
So health is much more than AI. You can put an algorithm to it, but behavioural science and the way a patient reacts, that relationship you have with that patient, it is what's key to medicine, and it's an art. As much as it's a science, it's actually an art. And I think AI will be brilliant in presenting us on a population health basis where we need to allocate resources, our need. But actually, that conversation with the patient, that final clinical decision, is actually made mutually, I think,
Yes.
with the patient. There'll be medications I recommend that I'm like, you will have a heart attack in 10 years if you don't take this. People don't take it.
Of course.
People don't take it. So it's so different, medicine, and I'm not scared of AI, actually. I think it will only improve the way we deliver health. But at the end of the day, the clinicians, the healthcare professionals, the social care, our wider communities are the ones that actually facilitate the change.
Yeah.
And I think that's what's really interesting.
Yeah.
So I'm excited about population health. I'm excited about AI, only because then I will know where my greatest effort needs to be put.
Yeah.
To basically be able to get better outcomes and improve people's healthy years lived, improve the next generation of children, and really start to make those fundamental shifts that we haven't really seen in 10 years. The Marmot review has told us we haven't really significantly changed, and what we've been doing, and don't get me wrong, the COVID-19 pandemic's probably skewed our timelines.
Of course.
Isn't quite working. So we've got to do something radical, and we've got to do something different. And the digital enablers allow us to do that. If we can try to start to embrace them into our current embedded standard operating policies with the art of medicine.
Yeah. Is there a potential concern, however, that that digital health is used as an excuse or a reason to not increase the actual number of people working within health? So, this is just devil's advocate, really. Could ICBs or NHS England say, actually, we don't need as many nurses and doctors and social care workers as we did before, because digital health is going to mean we need 20% or 25% less. Do you think that could be an issue?
Yeah, I don't actually.
Okay.
I don't think there's enough of us already. So actually, I think the opposite. I think we need the digital to make sure the people that we have on the ground and those coming through are using in the right place at the right time. So do I think we're doing things we shouldn't be doing? Yes. And that's the levers, the contracts, and that's where I think we need to get smart with the data and the contracts to understand, to make sure we're doing not the right, but the most appropriate things in the right places within the system. So I think it's about reorganising the way a system works collectively, and that's not just health, with social care. How do we start to build integrated teams around the right people? And we're missing people in the population, and that's what the data will give us. And how do we go from a reactive state, which is what we're doing, we're trying to react to what we're seeing, to using the data in a proactive way, that we actually start to reduce the burden of disease. And that's where we really need to get to. But it's a really brave move to make, because we've never done it. But I don't think we've ever had the data to do it. And I think we've never had the digital enablers. And I genuinely believe fundamentally now we have all of that in place. And now it's about influencing our colleagues, our systems, to be brave and courageous and innovative in absolutely new ways of working. We need to move from transactional to transformational. We need to change the contracts from transactional to transformational. And we've got some great leaders in the system that are, trying to make that happen.
And what's stopping that happen at a more rapid rate? Because, as you say, we have the data now. We have the ability to look at the data and to analyse all of the data, in terms of the population health. And we have lots of willing people to make it work better. Why isn't it now? Because there's a lot happening now, but it's not happening quick enough. I don't feel that it's happening quick enough. Is it who are the people putting the brakes on that? Is it because people just aren't brave enough? Are they, because COVID-19 was absolutely the tipping point that I think digital health has been waiting for, which you mentioned. Why aren't we moving faster? I get the feeling, I don't know if you do, that COVID-19 happened, lots of people signed up for the NHS app. They were registered for the digital services that you mentioned more locally. It's almost like COVID-19's gone now, or it's some people have got it, some people haven't. And that initial rush has happened, and that urgency. And we've gone back to very much Okay, well, we can just take our time again now. That urgency seems to have gone. So what do you think that's the case? And if that is the case, where are the breaks in the system?
Yeah, so I think the red tape was ripped off in COVID-19 and we learnt a lot. I think what was really interesting is we moved really fast, and one size doesn't fit all. That's what I've actually fundamentally learned. Every system has got its own nuances, but I think it's about creating an overall strategy, like you're saying, but actually how does it work for your local system thereafter? And I think it's about understanding that and what are the digital enablers that work at strategy level that everybody should have, and then start to kind of work out the nuances to make the data really smart at local system level. I think the current financial climate doesn't really help either, which means we can't move as fast as we want to. I think populations have been hit quite hard by COVID, so at the time communities were engaged and willing to come to the forefront and work with the NHS. I think now, with the cost of living and the word attendance health and going back to normal life and it's all rising, and the pressures are quite severe. So actually people's health goes on the back burner. You know, I've had people more than ever come into my surgery and go, Dr. Kumar, can you just help me get some food for my family? And that has fundamentally changed. So we do need to move faster because of what's happened. I think we're trying to move as fast as possible. But I think, as I said, health is an art and not a science. So I think we're trying to make it a science, and therefore we're not moving as quickly as we can. And when good pockets of innovation take place, we need to spread quickly, and that's much more difficult. And how do we make it work for every area? You know, rural Cornwall is very different from me up in Slough. They have their own problems, don't get me wrong, like the coastal issues. But how do we get to a place where actually the strategy we have, the Call 20+5 national strategy, but how do we start to make it work for everybody? And then actually, if my area is similar to Leicester and Manchester and Birmingham, our populations are similar, how do we get all those towns and people from those towns and the leaders to actually work together? So across ICSs where populations are similar. But that's all from the data, right? So we need to really, and that is smart, but I think it's extremely difficult to scale at pace. Because you create silos by doing that, and that's what I think people are scared of.
No, you're right. And actually, I want to just go back to something you mentioned that no one has mentioned before, but it is actually pertinent. You spoke about patients coming in and saying, actually, can you help me get some food? And we haven't touched on that before in this podcast in terms of, but I think that's it's a really key point that you've made, is that we want to help people with their health, but at times like this where there is a financial crisis, everyone feels it, that fundamentally, yes, my health is important, but I need to be able to eat and feed my children or my grandchildren, whoever that might be. I think that helps put it into perspective a little bit, is that all the work that we do, the patients at the end of it, can we really engage with them if they're hungry or worrying about those fundamental things such as mortgages, food?
Absolutely. I mean, in Slough, we embarked on a programme about 2 years ago where we went out to about 3,000 residents, and we didn't ask about health, we asked about the wider determinants of health. So we asked about internet access, we asked about food, clothing, can you pay your household bills? Really interesting, out of 3,925 people, so they had fuel poverty issues. 1,400 mental health, 290 digital inequity issues, 290 food poverty. And actually we helped all those individuals from a social perspective. So we gave food vouchers, fuel vouchers, clothing, we got them into mental health services, and we set up Digital Buddies program with the community where we tried to facilitate and support people with digital literacy and equipment.
That's incredible, by the way. And was that initiative, where did that start from?
So that started really from our leaders in our system. Jim McDonald, he's very much like, we need to support people's social need to basically improve their health.
Yeah.
And
was that at from the PCN, or was that from
the whole of
ICB?
Slough? So we did
Slough.
it across the whole of Slough.
Okay.
So all the 15 practices were involved. That we embedded our social prescribers at that time.
Mm-hmm.
So they asked the questions. We identified the people in the population from our population health analytics dashboard in Connected Care. So we looked at deprivation deciles 1 to 3 with 2 or 3 chronic conditions. We purposely did that because we wanted to access the 40 to 60-year-olds in the multi-generational households.
Yeah.
Because they're the ones serving the children and the grandparents. So as you can see, digital was an absolute enabler.
Well, that's what I'm thinking. As you're saying those things, and that data's come from Connected Health.
Connected Care.
Connected Care.
Which is our linked data set across Frimley. We've been building it for about 8 years, where we have a linked data set across health and social care. So we have one-on-one data out of ours, A&E, social care data, primary care data, all sitting in one database.
Okay. Is that replicated nationally, or is that something that's very...
There are a few sites nationally
Okay.
that have replicated that across the country. I don't know exactly how many sites, but not widespread.
Okay. Seems
so
like it should be. Sounds like it should be.
It really should be. I mean, we've actually, our analytics team is absolutely fantastic, and they've even incorporated housing size, EPC ratings of the house. So how much heating have we got in the house?
Yeah.
So we're looking at overcrowding, we've added deprivation decile, so really trying to bring health and the wider determinants of health and all the kind of services that sort of serve this community. So the data is very intelligent now, as I said. But what was unique about that project, we also coded each of the questions. Okay. And that's how we found out of the 3,000 on a population basis, 925 had fuel poverty. And these are the things we can start to do. Yeah. And therefore, and we have the addresses of those people. We can text them through AQRX. We know that there's only 10% digital inequity in our system now. Yeah. So we know that we can use the digital route as much as we can for the 90%, but the 10%, we need to have safeguards in place that we're not missing them in the system, and use our resources to ring those patients. So what we did end up going to do was we digitised that questionnaire and have tried to send it out to our population. It's a pilot that we're doing right now at Kumar. And those that don't respond, we then do a phone call. Okay. And actually what happens is when they answer the question, if they say that, yes, I have food poverty issues, they get an automatic text message to the local food bank. Oh, wow. So we're trying to support them in real time. Yeah. And what was really interesting about that programme is we saw a 9% reduction in A&E, we saw a 15% reduction in inpatient admissions, we saw a 3% reduction in ambulance use, and we had an increase in 12% in general practice use. Because what we were trying to do was support them with their diabetes. Because we interacted with them in a different way, like you were saying, help them get food on the table. That changed our relationship with those families. Yeah. And they're like, okay, let me listen to the healthcare professionals about my diabetes. Because they're actually only trying to help me. Yeah. But I think we need to get to a place where we're thinking about the need of the individual and their family. And then we can have that conversation with them about their health in certain situations. Yeah.
Those numbers seem quite incredible to me. Was that across Slough?
That was across Slough. When we looked at those that engaged with us with the questionnaires and those that were offered the questionnaire and didn't engage with us, that was the difference between the cohorts. Yeah, that's quite incredible. And so I'm really interested in you talking about social care, because that example you've given is really, what I think about an ICS or an ICB is about bringing those services together. And the example you've just given there is amazing, really, because that's what they've been brought together for. That's what they're formed for. That was the idea, to bring social and healthcare together. And I know it's such a big challenge across the country. And I wonder if it's because of the challenges you have here in Slough, and you said they're replicated in other areas where there are high percentages of multi-generational households, but also multi-ethnic. Because those challenges, it brings out the best, and you have to search for those solutions. That's what I'm getting the kind of the feeling for. Absolutely, but I think the digital enabler has been interesting. So connected care has been really interesting for me. I mean, I've been part of the team since the inception.
So talk to me about that, a bit more about connected care.
I guess all we wanted to do as clinicians and analysts and some of our digital folk who are absolutely amazing, if I must say, we just wanted to share data across the system. So we knew the patient's journey. So if a patient turned up in A&E, there was some information about them. We just simply didn't even share our EPRs, which is really interesting. Whereas patients think we already do.
Of course they do.
You know, if I turn up in A&E, of course you've seen my GP record. That's not the case. So it took so that's where it really started from. We just wanted to share information about patients. What became really interesting, and again, I bring it back to the COVID-19, we realised we can then, in a population, we built a population health analytics tool, which is in-house built by our connected care team, that we could find the person living on their own that was COVID-19 positive. So in a population of 1 million, we found the 6 houses where somebody was living on their own. So population health isn't always about scale. It's also about individuals. And we were able to give greater support to that person in that household during COVID-19, just because if they collapsed on their own, no one would know.
Yeah. So I just want to, that's incredible. It really is. So a legacy system that wasn't really used in this way before, COVID-19, you were the team that were working there, thought we can do this.
Yes.
And we know the horror stories, where people were left alone and no one knew they were there. Yeah. What you're saying is, because of this legacy system, this digital health that you'd embraced years ago, enabled you to say, let's identify those people and offer them more support.
Yeah. And that's where our remote monitoring service started from. Yeah. We started to measure their oxygen levels. They could type it into the app, and then we knew that their oxygen was fine and they weren't deteriorating.
So you dropped them a pulse oximeter, show them how to use it.
Yeah, and there was an app, they downloaded it, and then they used it, and then we spread that across just it, and we saved lives. You know, we could see people's blood saturation suddenly drop, and then we knew we had to get them into hospital. Yeah. So then we were actually utilising our resources in COVID as best as we could in the pandemic.
So keeping people out of hospital, away from any, until the SpO2 levels fall to a point where you say, okay, that's critical, send an ambulance.
And reducing the spread of infection. Yeah. So it became really powerful, and once that seed got planted, then all these other new ways of working on a population health basis came out, and that's even where the seed of the multi-gen started. So we knew that families in multi-generational households had a worse outcome in COVID-19 because of the spread of infection. So we tried to do many more different comms with those families. And that's where the seed of multi-gen kind of started.
So you sorry.
Go ahead.
Sorry. So you identified the multi-generational household using the connected care as well.
Platform.
Okay. Yeah. So talk to me then a bit more about the challenges of multi-generational households, because you said the number here is high, as would be expected. So talk about challenges of them and what you've done with those.
So I would flip it, it's not a challenge, it's an opportunity.
Okay, great. Yeah, I like that.
So we have about 12,000 multi-generational households in Frimley, 3,761 in Slough, which is approximately 13.9%. And what's been really interesting is we've used reverse population health analytics to find the households that are not engaging through the traditional routes of primary care. So actually what really started is we went out to our population, and we thought there was vaccine hesitancy with regards to the preschool boosters with our children. And what they actually said to us is, if you come out and give us the injection, we'll take it. So it wasn't per se vaccine hesitancy, it was the fact that it was transport. Okay. Or, they couldn't get to the surgery at the time that it was opened. Yeah. So that's exactly what we did. But what we realised is, if we were going in to vaccinate the child, there were 8 other members that had outstanding health checks that we could support. So if phase 1 of the multi-generational household was just vaccinating the children, but looking at what else is in the household outstanding. And within a space of 2 weeks, at the end of the contract year, so these are families we've tried to engage with the whole year, we achieved 68 more injections.
That's incredible.
In a space of 2 weeks across the whole of Slough.
Yeah.
So what we decided in phase 2 is, let's look at the whole household and the missing indicators. Out of the 3,761 households that we identified across the population, we identified 441 that were not engaging through the traditional routes of primary care, and we created an outreach program.
Okay.
So these are people that were not coming in for their health checks, not people that were, people that were not. So that's what's really important, the exclusion criteria, because these are people that health continues to deteriorate. The ones that we're potentially saying the wider determinants of health are actually affecting them in accessing health. And we went out. And what was really interesting is the way we set the incentive scheme. We didn't set it on activity, we set it out on outcomes. Our Slough GPs and their practice went above and beyond. And they actually ended up visiting or interacting with 889 households across Slough with this criteria. And we had a doubling improvement in primary care outcomes when it comes to QOF, but we had a 45% improvement in public health indicators, cervical screening, bowel screening, breast screening, immunisations, which was really an outcome we didn't think we'd see. And that's fascinating because that's where the prevention work comes in, and that's where the real, can we stop disease from even developing, because we know these communities don't access these services. And that's year on year. And the other thing is actually we were one of the best places within the system with the highest outcomes with learning disabilities and the checks as well, because specifically out of the 441 we identified 81 households that had learning disabilities and reached out to them and their carers as well. So really going back to the core 20+5 national framework, how can we start to facilitate change for the households that aren't interacting with us? What was really interesting though is that we would offer a household visit. Not everybody wanted a household visit, but they came into practice. Just by even offering a different way of access, they still engage with us saying, we're here, we care, we're specifically reaching out to you, we know you're not coming to practice, we'll come to you, and they came to practice.
So the perception of the patients changed towards you as clinicians because you reached out to them.
And thought about their needs and potentially their timings. And general practice has significantly opened its doors 8 till 8 and on weekends now. So we have listened to our communities. But I again, going back to the art, I think it's that interaction and, oh my God, my GP really cares. We know how busy they are, but they're willing to come out to me. Oh my God, I must go see them. Or the other thing which was really interesting is when I did the household visits initially, we vaccinated the children. I purposely booked the cervical smears at the time for the women. They all kept their appointment, and maybe that's because I reached out at a time they needed for their children that we can't do smears at home, that they kept that appointment and didn't DNA. So it's really interesting because I think you start to create scale. So out of the 441 households we identified, that's 4,000 residents you're interacting with. And I had a really interesting question last week about sustainability of it, saying, generally these communities come, you help them, they improve for 3 months, and then, it starts to wax and wane again because of life pressures. And I said, I think the difference with this model, and I can't prove it yet, hopefully in a couple of years' time we will be able to, is that you're not interacting with one person, you're interacting with 9 people.
Yes, the whole family.
And then lots of people are like, people wouldn't want a home visit and look after the whole family. People don't want to know each other's business. Families know each other's business, and as long as you get consent, and we did. One visit I did, the wife actually said, Dr. Kumar, can you please talk to my husband? He smokes. I would never have. I have it in my record.
Yeah, but you'd never be able to speak to
him about it because she brought it up.
Yeah.
And that peer-to-peer support, and I fundamentally also believe that maybe the younger generation weren't aware of the bowel screening. So now we've improved bowel screening. And these numbers are quite significant.
They are significant. The numbers you've just given are incredible.
Yeah, we haven't seen change like this in the last 10 years in Slough, and we really want to continue the work. But the data has enabled us to do it for the first time. And that's where I think the data is really interesting on a population basis. Where do we get it right for 80-90% of the patients or the residence cycles in a really efficient way? So those that interact with us, those that know how the system works, those that have the language and the ability to be able to interact through the traditional routes. And where do we use the data in the reverse, DNAs, not attending, on a population basis to understand what kinds of ways communities want to be engaged with, and I think that needs to be completely co-created with the communities.
You said some incredible things there, and what you're actually doing in Slough is amazing. I think talking about taking that data and using all these initiatives, because there is so much data out there, and I don't know for sure, but I don't think every GP is like you and the community of GPs you have in Slough. They're being so proactive and saying, okay, here's the data, we're going to do this with it, and we're going to take these initiatives. And the fact that you said this is an opportunity, I'm saying it's a challenge. You said no, it's not a challenge, it's an opportunity, and I love that. This really proactive nature. Can you talk to me about the teams that went out to the households? It's obviously it wasn't all you and other GPs, so there've been community teams as well. What do those teams look like? How are they made up?
So the initial phase has been quite health orientated. So phase 1 has been physicians, associates, GPs, nurses, initially going out. I mean, in the second phase, the GPs didn't go out. It was nurses and physicians, associates. We always had 2 people going out. But we left packs with the families with regards to use of urgent care, social prescribing, the voluntary sector. You know, if we knew there was a drugs and alcohol issue in the house, we'd just leave a leaflet. Just that little signal.
Yeah.
Actually, in the first phase, in phase 1, we did record how many social prescriptions were made. 25% of those households went on to have a social prescription. Yeah. So the social prescribers didn't quite come into the house with us, but it gave us an insight into the house environment as well, and what things we could offer. So we would have those conversations. And by even simply leaving the leaflet and that interaction, we saw, a slowing of urgent care use in the multi-generational household. And this is all important because it all comes down to activity and the way people use our resources, which is really important for us. And this is about getting the right services to the right patient first time. And going back to that ethos, if we fundamentally get that right for patients and their families, we will fundamentally start to look after the entire population. And that's what's really interesting. And I think we're just at the edge of turning the key. And you say I'm a proactive GP, but actually the fantastic analytics team, operational people, leaders within the system that have given me the opportunity to be able to, even the voluntary sector, every year we have a social prescribing day and we go out and ask the communities what they want. So even that, asking the residents, have all been part of these amazing changes we've been able to facilitate in Slough. And the people have been as important as all the wider teams. Yeah,
of course. And I think one of the great things with social prescribing, identifying these households and these people within the households, is that, as you said, the 25% increase in social prescribing means that those services that are established get to be used, because there's nothing worse than setting up a service, knowing that it's vital and it can be used, but no one's subscribing to it. So no one actually using that service, so the funding goes and they disappear after a year or whatever.
Absolutely.
So that's another great reason to identify the cohorts, isn't it?
Yeah.
So.
And this is what we did even with Digital Buddies, like through the questionnaire. We weren't simply asking people to fill in a questionnaire to have no solution for them. And that's what's really important. I think whenever you go out to communities, if you've listened to them, we need to do something about what they've said to us.
Yeah.
We can't just simply say, oh, we've listened and it's a tick box. No. What is the opportunity with that community to fundamentally change the way we work? And we've got to create an NHS for the people.
Absolutely, bring it back to the people. So Priya, the numbers are incredible. The work that you do and your colleagues do in the area really is amazing. Have you engaged further? Have NHS England come knocking on your door and said, "We've seen your figures. How can we replicate this more widely?" What's happened there?
So yes, we've had great support from Professor Bowler. She has been down. She came down to do a home visit with me. Okay. So really, really exciting. The RCGP is also following it. This is only phase 2. We're just about to do the evaluation and try and get it further spread across the country if we can, in different areas. Bradford has also started a multi-generational household, and from what Bola recently told me, there are other areas just starting to do it.
Yeah.
So it's really, really exciting. With the wider determinants of health questionnaire, I've had a lot of support from NHS personal care. The National Academy of Social Prescribing has also taken it up and looking into the data and seeing how we can scale it now. So I think it's about, obviously this has been great at small scale. I mean, Slough is 167,000 patients, something like that. It is scale, but how do we start to get it to work everywhere? And is this the right solution for everywhere? Or is it, what does that outreach program look like in each area for health inequalities? But the data will give us the answers.
It will. You mentioned earlier, Slough is very different to rural Cornwall or coastal Cornwall. Of course, it's very different, but the data will have the same effect if they can look at that. They can identify the needs or the opportunities in that area and provide the services and the resources that are needed for that area more efficiently.
Yeah, exactly. And it's what works for 80%. What doesn't work for 80%, and the answers are all right there in front of you. But let's do it with our communities, and I think that's where we really need to change. I think we've been doing on to and thinking, this is the right way to do this, the right way to do it. And don't get me wrong, in the financial constraints we have, we have to, right? Let's be realistic. There is only so much funding. But I think if we start to change the conversation, it will change the outcomes. Let's start with the problem and the people, not the resources. Let's start with that, and the money falls out.
Agree.
Eventually.
I just want to finish really by asking you, in terms of digital health and what it's really enabled you to do in this area, what hopes do you have, I think 5 years time, for your community using digital health possibly more widely? You mentioned integration. You're already using the connected care. What do you hope for 5 years? What does that picture look like?
I really want to get to a place where we're moving health and social care collectively together. And that emphasis on social care, I think, and start to change future generations. So, for example, with the household data, as I said, I felt the multi-gen was health orientated with social aspect on top. We have actually reversed that, where we're looking at families with children and parents with substance misuse and mental health, and we're trying to create a integrated care team around that family and those children. So parenting support, employment is involved in that, schools are involved in that, early help, immunisations. So we have the health bit, but we're also thinking about the wider determinants of health at the forefront of the problem. And what I really want to start to do is, how do we get that prevention agenda, which is probably the hardest agenda to tackle, actually, because people are like, well, why do I need it? It's not only health, actually. When I've gone out to these families, like, well, I don't need your help right now. Why are you coming to see me? But we can see there's signals within those families that actually in 5 to 10 years' time, they will become the multi-generational household, because they will have chronic conditions that they don't need to develop. So it's about moving with our communities, understanding their need, bringing them on board with us, part of us, saying, co-creating these services with them, and actually affecting those healthy years lived. I'd love to say we can make a dent in life expectancy, but I don't think we'll see it in 5 years' time. But if we can even make a dent in those healthy years lived and prevent disease and start to support our children in a different way, that's where I'd like to see us get to. And I don't think I may never see the outcomes in my lifetime, There'll be in generations to come. And I think it's about generational change is where we need to get to. And that takes a lot of changing from where we are right now in the way we work to where we need to get to.
Thank you, Priya. It's been an absolute pleasure to meet you and just chat with you today. Really wonderful. Thank you. And thank you for everything you're doing. It's really great.
Thank you for the opportunity to share. The more people we have on board, the more people that hear what we're trying to do, and collectively as a nation, then we can start to move in a different direction.
You're more than welcome.
Thank you.